This week, the textbook covered data visualization. But what data do we need to gather in radiology, and where do we gather it from? Before we can make all those beautiful graphs and charts, we gotta have the data to begin with. And the easy answer is we gather whatever data the radiology director wants us to mine, and we get it from wherever we can find it. There are some common data requests, and so let's take a look at them now. The common data requests are for information involving time between steps in the workflow, procedure volumes, turnaround time, employee productivity, and machine utilization. Most data mining requests will come from the radiology administration, such as the radiology director, the radiology operations manager, the radiology business office, and occasionally radiologists or project managers. Let's start with an easy one, procedure volume. It's used to answer questions like, how many CT scans did we do last month? Are the total number of procedures we do each month increasing or decreasing? And other volume-related questions like that. It's pretty easy to gather that information, and the primary place to get it is from PACS. If you say turnaround time to anyone who works in radiology, they will usually assume you're talking about the time from the completion of the exam to the final report signage, and that's radiologist turnaround time. That's the most common thought most radiology people have. However, turnaround time means different things to different groups. To the requesting physician, it means from when I ordered the test to when I got the report back. To the patient, it means from when I got scanned until I found out the results. And to the radiology director, it means from when the exam was done until we submitted a bill for it. So turnaround time can mean different things to different groups. If it's radiologist turnaround time, you'll find that data in the dictation system. Everything else you'll probably have to get from the RIS, and keep in mind, depending on how the informatics staff is organized, you may or may not have access to reports from the RIS. You may have to request that information from the RIS administrator. Employee productivity, as the name suggests, is about employee productivity. Which technologists are doing the most exams and which ones are doing the least? Or which radiologists are reading the most exams and which ones are reading the least? For both of these groups, you need to use RVUs. RVU stands for Relative Value Unit, and it's a way to help equate the workload. Let me explain. Let's say one technologist is doing chest x-rays for the next hour, and one technologist is doing lumbar spine x-rays for the next hour. A chest x-ray can take 3 to 5 minutes to do, and it's only 2 views. A lumbar spine is 5 views, and it takes 15 to 20 minutes. So at the end of the hour, the tech doing chest x-rays has done 10 exams. The tech doing lumbar spine exams has only done 3. If you just count the exams each tech did, the chest x-ray tech is outworking the other tech 10 to 3. And this is where the RVUs come in. Basically, you assign each unit of work a value. In this example, we'll say that chest x-rays are worth 1 point, and lumbar spine exams are worth 3 points. Now, if we apply the RVUs to the work that 2 technologists performed, the tech doing chest x-rays scored 10 points. And the tech that did the 3 lumbar spine exams scored 9 points. This is a much more realistic picture of what is actually happening. Using the RVU point system shows that both technologists had a similar workload over that hour. In general, tech productivity data will be mined from the RIS, and radiologist productivity data will be mined from the dictation system. Machine utilization, in simple terms, is which image acquisition devices are we using the most and which ones are we using the least. There are several contributing factors to this data. First is how the machines are being scheduled. For example, do the schedulers default to the first machine in a work unit? In other words, when the scheduler goes in to make a mammogram appointment, does she automatically check Mammo 1 first and then move to Mammo 2 and then move to Mammo 3 as she's looking for open appointments? Is this why Mammo 4 doesn't get much work? The second factor is tech preference. In any x-ray department, there will be machines that all the techs prefer to use and ones that they don't like. In any x-ray department, I can pretty much guarantee you that nobody likes room 6. For whatever reason, it's always room 6. The techs will go to room 1, room 2, room 4 if they're open, but they will only use room 6 if they have to. In general, the rooms closest to the waiting room will get used more because techs don't want to make the patients walk to the back of the department. Obviously, this has an effect on the maintenance cycle. The rooms that get used more will need more maintenance. The third factor is the nature of the shifts in the hospital. In general, in radiology, first shift, 7 a.m. to 3 p.m., will be the busiest. Second shift, 3 p.m. to 11 p.m., will be less busy, and 11 p.m. to 7 a.m. will be the least busy. The techs working 11 to 7 won't have the productivity numbers that the tech working 7 to 3 will have. They just don't have that volume. And the overnight techs will only use the favorite rooms and never go anywhere near room 6. Almost all the machine utilization data can be found in PACS. Part 1 of the workflow focuses on the schedulers, front desk clerks, and technologists part of the workflow. It covers the steps from when the exam is ordered to scheduled and then patient arrived. From there it covers from when the patient is called for their exam to when it's completed and when it's put on the list of exams to be read. The time between each of these steps is measurable and important. For example, the time between patient arrived and begin procedure tells you how long the patients are waiting in the waiting room. All of these steps are tracked in the RIS system if everyone follows proper procedure. The key here is the humans have to follow the directions, and humans aren't always good at that. What should happen is before the tech goes out to call the patient, they should click the Begin Procedure button in the RIS. When they finish the exam, they should click the End Procedure button in the RIS. When they complete their paperwork and quality control checks, then they mark the study ready to be read and it goes on the unread list. And this gives us a nice timeline to track each of those events. But here's what really happens. The tech calls the patient back, does the exam, sends it to the unread list, and then goes to the computer and begins the study. They wait 1 minute and end the study. And so when you pull up their productivity data, it will show that it takes them 1 minute to do every exam. It's amazing. They did an entire lumbar spine series in just 1 minute because they're not following the proper workflow. So all this data for workflow 1 can easily be found in the RIS system, but the quality of the data is directly related to every human. They all have to do it following the proper workflow and not taking any shortcuts. Part 2 covers the radiologist workflow. It's the time from when the study was ready to be dictated to report signed to report delivered. The best place to get this data is the dictation system, which will most likely be a voice recognition dictation system that tracks all of these steps. You could also get this information from the RIS, but I prefer the dictation system simply because it has more data and you probably have more access to the dictation system than you do to the RIS. A lot of data mining is done on the normal radiology workflow. The time between each of these steps is very valuable. If you can shorten the time between steps, you can improve patient satisfaction and do more exams. Generally, more exams means more money. As I mentioned before, the time between steps 3 and 4 represents how long the patient waited in the waiting room. Time between steps 6 and 7 represents how long exams are sitting on the unread list. You can do other measures, such as time from step 3 to step 6, which represents how long it takes to perform a certain type of study. So if you want to know how long it takes to do a CT scan of the abdomen, you measure from step 3 to step 6. And that's very important information in a high volume area like CT. The faster you can get patients from arrive to complete, the more patients you can scan in a shift. This is not an all-encompassing list of data you'll be asked to gather, just a list of most common ones. Other types of data you may be asked to produce involve scheduling. This is an important one, and it's to answer the question, how long are patients waiting for an MRI appointment or a mammo appointment? If your next MRI appointment is 3 months out, it's great that you have that much volume, but patients and referring physicians are not going to be happy waiting 3 months to get a patient in for a scan. There will be data mining tasks related to billing, supply usage, costs, and of course, the medications, which are mostly contrast agents being used by the imaging department. Whatever data they need, it will be up to you to go find it and get it. Thank you for watching.